There's an episode where Lucy and Ethel are working at a chocolate factory. They're making boxes of chocolates, and there's an assembly line, and they're doing a great job. They're making those boxes of chocolates, and it starts going a little fast, and they have an accident, so they put some in their pocket. Keeps getting out of control. The boxes of chocolate are not getting made, and that is how I like to explain DNA repair defects to my patients.
I am so excited to have actually one of my good friends now that we actually know each other through the FIGS retreat for mental health, and it was great, and we're both still feeling, all the mental health benefits, which is very important for all physicians, especially those in cancer, arguably, and being biased. Dr. Anjali Malik is a board-certified and fellowship-trained breast diagnostic imaging specialist, and she's also a women's health advocate on social media as well as in news media. She's on the medical advisory committee for Bright Pink, and she inspires women everywhere on their ovarian and breast related health and just women's health in general. Anjali, we're so excited to have you, and thank you for being here.
Absolutely. Thank you for having me.
So I love that you're passionate about, kind of empowering women and men, again, 1%, about kind of what to do, how to do it, and some of the scary stuff when they say we need more testing. So that's a great place to start and tackle. People get mammograms, and I've always heard is like, so screening a mammogram, all of a sudden they said, we need more. So that's very scary for a lot of people, but I guess one of the first things we should talk about is what percentage of those people that need something more just after that first one, just to look better, what percentage is actually a problem? Because it's a very small percent, it's just kind of being more prudent, right?
That's a really good question. So if we take, for example, 1,000 people being screened, women, cis, trans, everyone, 1,000 people being screened, about 100 to 150 people will be called back from screening, and about 20 of those will end up needing a biopsy, and then 5 of those most likely will go on to have cancer. So you start out big, you go a little smaller, but of that 100 to 150, a really small number of those end up having cancer. So the good thing about it is that the odds are in your favor. It's always just about that second check, making sure that we are taking care of everyone and eliminating any chance of there being cancer.
For sure. So you said 5%. 5% of the 20% that need a biopsy will be positive, or is it 5% of the 150 that are called back?
No, so it's actually an absolute 5. So of the 150 that'll be called back, 5 will go on to have cancer. So out of that 1,000 people screened, 100 to 150 get called back, 20 have a biopsy, 5 go on to have cancer.
So that's very important. So just so you know, if you get a call back, it's still not even, it's still better than 95% chance, still a 98% chance that you will not be positive for cancer. It's just looking at something better, right? And the reason for that is because ideally you want to do the most minimal amount to make sure you're good. So that minimal, mammogram, just the kind of your basic mammogram, what exactly is it? Is it X-ray? Is it like magnets? What is that mammogram that's happening that's a screening mammogram, and they're very big on billing for screening versus diagnostic, etc. What is a mammogram? What is the general mammogram most people get?
So a mammogram is an X-ray of the breast, and the standard mammogram is going to have 4 views, 2 views of each breast, one from top to bottom and one from side to side, to include the armpit, since that is an area that can either have breast cancer or have metastatic disease. And so these days, you might have heard of 3D mammograms or tomosynthesis, and I'm sure that's something that you were going to bring up, but just in case, I'll go ahead and cover it. So in the old days, which is still includes the time that I trained, so I think that makes me old. We did just 2D mammograms, which were just the picture, basically, right? So just one picture in this direction, just one picture in this direction of each breast.
Like a chest X-ray, like a 2-view chest X-ray. You get one from the front, and ideally you get one from the side. Okay, that makes sense.
Exactly. So it was like a 2-view of each breast. But these days we have the 3D mammogram or tomosynthesis, which is kind of like a low-budget version of a CT. And what it does is it takes multiple views across different angles, doing those 2 views. So you're still doing a top to bottom kind of movie of the breast, and one from side to side. So, a lot of women or those who have been screened in the past will be able to tell you that when they got called back, they were told, it was just overlapping breast tissue. So those callbacks, so many of them that went on to scare people and give anxiety, were actually just related to overlapping breast tissue. And this 3D mammography, which lets us look at the breast layer by layer, eliminates a lot of that, those false positive callbacks, and also enables us to detect small invasive breast cancer. So it increased the detection by about 30 to 40%, and it decreased the callbacks significantly. So it's a great technology that we have, and it is available most everywhere now. It's actually mandated in several states to include like New York, Missouri, Texas, all over the country. So
and that's as a screening.
And this is a screening exam, exactly. So the only difference between a screening and a diagnostic examination is that screening is done for asymptomatic patients, so they don't have any symptoms. They're just there for their routine checkup, for their annual breast cancer screening, which starts annually at 40 for average risk, and earlier if needed for high risk or any family history. And then diagnostic means that it's being done for a symptom, for example, a lump, a region of pain, changes to the nipple or skin, or it's being done, for example, for someone in the first 5 years after breast conservation therapy or a known gene mutation, things like that.
Right.
Those are the main differences.
So for those people, and there's a lot of, people in community practices where Tomo is not offered, or they may not know to ask, but they will now, thanks to our wonderful guest who's educating us all about these breast cancer screening techniques. But the places that Tomo is not available, how worried should a patient be that they're getting suboptimal screening?
So, I mean, in comparison, yes, we know that 3D performs better than 2D. But of course, for the longest time, 2D was all that was available. It still does detect breast cancer. It still is able to reduce mortality. Annual screening reduces mortality by 40%. That said, women and those being screened should be given access to 3D mammography. And if it's not available in a community center near you, I would strongly recommend finding out, working with your physicians to find out where you might have access to that. And again, this is where advocacy comes into play. That's why we as physicians and then patients and the public need to be taking charge of our overall collective public health to be ensuring that everyone has equal access to the greatest technology.
For sure. Okay, so that kind of addresses the screening part. And we said like of 1,000 or so, 100 have gotten their screening, Tomo, 2D, whatever, and now they're called that they need additional imaging. What is that additional imaging usually involve, and what are some of the main reasons that they had to be called back? You already identified one, which was the overlapping breast, if it was not a tomography. What are some of the reasons that are not cancer that they require additional, basically investigation, and then what does that investigation involve?
So when I'm looking at a screening mammogram, whether it's 2D or 3D, I'm looking to see what changes there are, what the breast pattern is. I'm comparing it to prior mammograms, if any are available, and I'm making my assessment. And so an assessment of 0 means incomplete, and all it means is I would like some kind of additional evaluation. And the things I'm calling screening mammograms back for are what we call asymmetry. And that asymmetry often does go on to be overlapping tissue, even with the 3D mammography. Now, the chances of that are much lower with 3D mammograms, but not 0. It could be a mass, and that mass could, on additional imaging, go on to be a totally benign mass. So if you see on your report that it says there's a mass in the right breast, that's all that means. It means there is a mass. We're going to do further imaging to see what that mass is. It could go on to be a very benign, totally normal cyst.
And probably
will,
right, according to the numbers.
Right. Yeah, it could be a lymph node inside the breast, which are totally normal. Those are the glands that drain the fluid in our body. We can have them anywhere, head to toe, including inside our breasts or in our underarm regions. And or it could be calcifications. Now, microcalcifications are very common in the breast. We see them in the breast for a lot of different reasons, most of which are benign. We keep a close eye on them because they can be an early sign of breast cancer, and we take extra images to sort of characterize them. On a screening mammogram, it's just going to say there are calcifications in the left or right breast, period. There shouldn't be any characteristics defined because we need those magnification views to define those, and I'll talk about what those are in a minute. But so the screening mammogram report is, I want to say, intentionally vague, but not to be evasive. It's intentionally vague because we just need more information. All we know is there's something, and we need to figure out what it is. It's like those picture pages, right? Like one of these things is not like the other. We're just identifying the thing that's not like the other, and then we're going to call patients back, do those extra images, extra imaging, and see what it is. So what are we going to do? For many of the things, we are going to do additional mammogram pictures. And now I do have patients ask me all the time, well, did they not take good images the first time? That's not what it is. It's that we need more information. So our standard 2 views for most people are going to give us all the information that we need to be able to clear them for that year for breast cancer and saying, you're good to go. We'll see you next year. But for some patients, we need to take additional views, either at different angles or of a focused part of the breast. That's called a spot compression view. So a normal mammogram might have a compression plate that's about this big. A focused spot compression will have a smaller one, and it'll allow us to really press into that one area. Of course, it's not fun, but it does eliminate a lot of the callbacks. The other thing, like I mentioned with the calcifications, is the magnification view. Literally, imagine a magnification or a magnifying glass. That's kind of what we're doing, and we're getting all those characteristics to be able to say, these are round and totally uniform and normal, and we're totally okay with these. These are totally benign calcifications. Or we're getting those like, these are really suspicious looking, they're clustered, they're, this, that, or the other. So we have all this lexicon, we have all these characteristics that we're looking for on those images. Now, for masses or for areas that are still there on those extra views, you might be told that you need an ultrasound. Not everyone needs an ultrasound. It's okay if you don't get one.
So that's a big distinction. If it's just like something that is obscure, meaning like hard to really delineate, then that's usually just more pictures and more angles with mammogram-ish technology.
Right.
But for masses, as a general rule, that's why you're getting ultrasound. You don't need to fear if like you got another mammogram coming in for additional testing. It means like, well, are they missing?
Right.
Is it sub evaluation? No, that's because that just makes more sense. Whereas an ultrasound is for masses or something. What was the other reason you said in addition to masses?
Masses, or if it persisted on that additional imaging,
Right.
or if it's a an axillary mass, or if there's changes to the skin, for example, like skin thickening or nipple changes, we might further evaluate it. So, and then that ultrasound, because it's a totally different technology, right? So you've got mammograms that are X-rays. They're using light particles to penetrate the tissues and show us what the breast looks like inside. Ultrasound is using sound waves, and it also delineates the different tissues using those sound waves, and it actually allows us to look inside masses so we can see if something is solid, we can see if it has fluid inside, we can look at its borders to see if it's nice, round, and smooth, or if it's irregular. And again, we can look to see, for example, if it's a lymph node, if it contains fat in the center of it. Now, I've had a lot of women who, when they come back to us year after year, they'll say, well, mammogram didn't find my cancer, ultrasound did. And while I'm not saying that's not possible, what many don't realize is that we don't do the ultrasound because the mammogram is bad. We do the ultrasound because we're like, oh, the mammogram detected something. Now we need to get this other tool out in our belt. So it's like, I'm not a handyman or woman, as it were, but like we have a lot of different tools in tool belts, right? And it doesn't make, just because one doesn't do the entire job doesn't mean it's bad. It just means that they work in concert. So mammogram is really good for screening. Ultrasound, its forte is a little bit more in diagnostic or focused imaging.
Well, that makes sense. And I think one of the examples is like, we recently bought a new house, and you get an inspector, right? And then you have this basic idea of like, okay, these look good, these look don't, and then somebody may say, when the inspector says something doesn't look right here with the AC or with the heating or the gassing, then you get a specialist and come and just get more diagnostic evaluation. Sometimes it turns out to be fine and not a reason not to get the house. And sometimes they find something that was pretty, difficult to ascertain. You don't say, well, they would have, it was them that found out, the inspector. If everything checks out, then oftentimes you're not calling that specialist in. And then some small percentage of time, or some percentage of time, seems to be every time for us, there's something there that like wasn't told us to investigate. So in an ideal world, if you're paying out of pocket, like same with everything else, like sure, full body MRIs, every 6 months, like some doctors do apparently for screening and all this stuff, just in general. But it totally makes sense. And an ultrasound, just so people understand, it sounds like it can be pretty darn good, and in certain circumstances, certainly superior to an MRI. Everyone just wants to go straight to an MRI, but you could be doing an MRI for a cyst that you find out on an ultrasound was a cyst, and then you have avoided the MRI, you avoided the cost. So there are some things that an ultrasound can characterize that are benign. Now with a mass that may be malignant, of course MRI delineates more, but it's got very high cost.
So everything is different. So, we do things, and I like that example of the house inspection, but we do things for different reasons. And MRI is definitely when we're pulling out the big guns for either high-risk screening, dense breast screening, or extensive disease workup.
Right.
Or like for, of course, something that you deal with is if your patient's already on chemotherapy and we're following their response. So, and we can definitely talk about high risk and dense breast screening, but I don't like to pit my modalities against each other.
I don't either. But I think people get insecure. I'm just saying, like, people will say, like, they just don't
Yeah,
ultrasound. Why aren't they going straight to MRI? And the reason is to
right.
say there are some benefits, of
To
one
one
to the
versus the
other,
other.
which is why it's like it's not
Yeah.
that just one is just hands down better for every reason. It could be
Right.
overkill.
Well, and patients will ask me too, and this is kind of similar to you using the house analogy. People will say, well, if MRI is better or if ultrasound is better, why don't we do that on everyone? And I kind of compare it to TSA screening. So, everybody's bag goes through the conveyor belt and it's some very low budget form of like CT, right, that it's going into. Now, for most of them, they're able to clear and say, you're totally fine. And then for me, my hair straightener every time, or my mom's, aluminum foil wrapped Indian food, because, moms, are always going to like go off like a light bulb, and I'm going to get pulled to the side and they're going to search through the things. Now, obviously, them searching through the bags is the most effective way for them to ensure that I don't have something dangerous. But if they did that on everybody, no one's flights would ever take off, in addition to already what's happening with flights across the country.
Right.
So yes, there are some modalities that are better than others. It's a matter of what is effective, cost effective, with that high efficacy, so high sensitivity, high specificity, that has the numbers, that is able to produce, but is easily accessible, quick, easily producible, things like that. So
No, that's
that's how
brilliant.
we decide to use our different
Yeah,
modalities.
I love it.
Hmm.
So, we touched on it. Everyone wants to hear about it, and it's
Right.
probably, arguably, at least for sure as it relates to breast cancer, my most common, DM is I was told I have, dense breast. They'll say, well, let's do one by one. First DM comes in, right? Because by the way, if I didn't say it, Anjali is also very prominent on social media, has a lot of followers, and that's because she's putting out good content and education that people just want to know and have a hard time getting information from. So number one, you're going to answer the DMs. I'm going to give you the DM question. You can answer the DM. Number
Yeah.
one, I have dense breasts. I'm in my 20s. Shouldn't I be getting MRIs, now every year?
So, a couple different elements in that question. So, there is no breast cancer screening done for anyone in their 20s.
Correct?
In the 20s, here are the things that I recommend to my patients. Number one, know your family history. It sounds like in this situation there was no family history. Family history does not just include breast cancer. It includes ovarian cancer, colon cancer, pancreatic cancer, thyroid cancer, melanoma. When we start seeing, a number of those on the same side, we question genetics. You had a great session with Dina DNA,
Mm-hmm.
who I love. And so, it's not just about breast cancer history, although, of course, that is going to be most often the most common and important one. Secondly, women or, my patients should start their physical exams in their 20s. If there is anything to indicate that the patient is a candidate for genetic testing, I absolutely recommend that. And I recommend that and a risk assessment be done before the age of 30. Reason being, if annual screening for those of average risk starts at 40, high risk screening can start as early as 25, most often 30. And so I want my patients to have that risk assessment, to know if they have a genetic mutation, to be able to set those protocols and get them set up for life. So the answer to in my 20s is know your family history, do your risk assessment, establish a screening protocol, which, most often is going to be see you when you're 40.
And what is a
And
risk
then
assessment, and how do you qualify for that, or does anyone?
anyone can do it. So there's a Tyrer-Cuzick is the most common risk assessment score that we're using. It is the most discriminate of the different ones that are out there. It takes in a lot of different factors. So age, menstrual history, so onset of menses, birth control history or oral contraceptive history, pregnancy history, family history, breast density, things like that. So breast density you're really only ever going to be able to address once you've had some kind of breast imaging, because breast imaging is the only way to tell density. So if your gynecologist will, do an exam and say your breasts are dense, that might be true in the setting of a physical exam. It's not true in the setting of breast imaging.
So tell us, and what
Um,
is that unit, or what is what are the metrics that, like, kind of like BI-RADS, right? BI-RADS is suspicious. 5 is definitely known cancer. 4 is highly suspicious. 1 is all good. What is the equivalent of that for density? What's the scale?
So we have four categories. They are basically going from least dense to most dense. And density is a proportion. So it's not a score, it's not a thing, it's just a proportion. So 1 is going to be almost entirely fatty replaced, 2 is going to be scattered fibroglandular densities, 3 is going to be heterogeneously dense, and 4 is going to be extremely dense. So these two, the last two, heterogeneously and extremely dense, are when we start talking about breast density, when we start talking about heterogeneously dense can obscure the detection of small masses. Extremely dense can obscure cancers and does put women at increased risk for the development of breast cancer. These are the categories in which we're going to talk about maybe some kind of complementary screening. So back to the initial, slide into the DMs question of should I get an MRI in my 20s? No, unless you have a known genetic mutation. For example, mom had BRCA and cancer at 32, then you would start some kind of imaging at 25. Those are nuanced questions, but end of the day, I recommend knowing your family history and having a risk assessment with your physician, whether that's your primary care or your gynecologist, to know what your screening protocol should be. For those who don't have access to that type of care, I was a medical advisor with Bright Pink, which has shifted its focus, but they do still have assessyourrisk.org, which does allow does empower everyone to be able to have that knowledge in their hands. You can take that score then to a physician to be able to say, hey, it looks like I might be elevated. I'd like to do this with you to ensure that that's correct, and then move on from there. So if someone slid into your DMs though when they were in their 30s or 40s and they had that question, I could address it a little bit better. So assuming that they had had some kind of breast imaging, which is what established that they have dense breast tissue, that category 3 and 4, the heterogeneously dense and extremely dense, is when we start saying, consider additional screening. It is by no means mandatory. It is optional at this point. In most places other than Connecticut, which absolutely requires women have a whole breast bilateral screening ultrasound. And that is actually because the first woman who started the whole breast density reporting movement, who actually recently passed away a couple of years ago from, I think, a myelodysplastic disorder from her initial cancer treatment. She was diagnosed with breast cancer stage 4 just a few months after having had a normal mammogram. And when she said, how is this possible? They said, well, you have really dense breast tissue. It just hid the breast cancer. No one was wrong in that situation. I've not seen her imaging, but I can imagine the scenario, and I'm sure you can as well. And that is why her movement started breast density reporting, which is now done almost universally across the United States. I haven't checked the latest, what states might be still lagging on that, but most states, and including the District of Columbia, do report breast density to women to be able to inform them in case they might need additional imaging to have those conversations with their doctors.
So what is unique about Connecticut compared to everywhere else?
That's where she was when she started that.
But what is unique?
So then I think they just, because that's where the movement started, they then mandated bilateral breast screening ultrasound in addition to screening mammogram on any women who are detected, found to have dense breast tissue.
So anyone found to have that 4th category dense in Connecticut, it's to be accompanied by an ultrasound because of that's very inspiring. Do you remember her name?
Nancy. Nancy is her first name, and if I were to get on Twitter or Instagram really quickly, I'd be able to find her last name. Happy to do that after the episode. But if you go to Are You Dense or densebreast.org, they probably even have maybe something in memoriam. Repella. Exactly. That's what I was going to say, but I was like, it doesn't sound right. So when we talk about dense breast screening, so 3D mammography was a game changer. At the time when she was starting this movement, we were still doing 2D mammograms, which we've already talked about. They, could obscure, they could have overlapping breast tissue. You couldn't find small invasive breast cancers. 3D mammography can help, see the breast tissue layer by layer. However, we still know in, some cases there's still going to be decreased, not zero, but decreased sensitivity and specificity. So what are the options? So if a mammogram, to include 3D mammography, detects 6 to 8 breast cancers per 1,000 women screened, the bilateral breast ultrasound can add up to 3 additional breast cancers detected. Most of those studies were done when we were doing 2D mammography, and in fact I was part of one during my fellowship. However, ultrasound can be an option, and of course it's a much more accessible, cheaper option than MRI. However, MRI is the big guns, no questions asked. It can detect up to 15.9 breast cancers per 1,000 women screened. So it can, in many cases, double and or more your level of breast cancer detection. It has the highest sensitivity. It does have false positives. It can be expensive. It does involve contrast, and there, for women with renal disease, that can be a problem, as well as there can be some size restrictions, and then issues with claustrophobia and anxiety, which can be addressed, but still, it is not the most accessible. So that's when we talk about, we're not going to open everyone's suitcase up, but if it makes sense to, that is the biggest, baddest option that we have.
DM number 2 is, I have dense breasts. I'm told I have dense breasts at least. I'm in my 30s. I'm 35. I'm out in the community. I do not have a family history. Should I be worried? What should I tell my doctor? And DM2 can actually be from primary care. I get a lot of primary care doctors asking and practitioners. Mm-hmm. What do I do? They have dense breasts, and they're concerned about it. What's the next step? And is it linked, which you kind of said yes with the risk calculator, of course, is always a component. So there is an increase. It's not like having a BRCA mutation, but it's, right. it's just, it's something along with, even weight and obesity that is correlated.
Right.
So what are the next steps on someone that's really concerned in 35?
So again, I'd wonder why someone at 35 was doing screening and would have that conversation with them. But
usually they speak vaguely. So they say that, they're doing self-exams, or like, a primary doctor did it, or OBGYN. So they're getting their pap smear or whatnot, and then they sometimes, OB-GYNs will do a breast exam and say, you have dense breasts, fibro-dense breasts.
Right, fibrocystic, right? The garbage term of fibrocystic breasts. I think a baseline mammogram is certainly an option for women in their 30s if they want to establish what their breast density is, or if there's some concern. Or many doctors will just do one at 35 or 37. That's been a tradition around my area, at least where I practice. If there is an actual concern for a lump, of course, that would get a diagnostic exam and a proper workup. But otherwise, if there is no family history and it's just sort of vague, dense fibrocystic breasts on physical exam without any focused concern, my recommendation is to, continue with annual clinical breast exam, monthly self-breast exam, and I will, of course, detail that, and then to initiate annual screening mammography at the age of 40. So when it comes to self-exam, the really catchy phrase is to feel it on the first. I am not a proponent of that. I love that it reminds women to do their exam, but I believe in monthly mid-cycle exams. Now, of course, a lot of women are on IUDs with all the reproductive, everything that's going on right now with reproductive rights. That is, for many, the smart decision. For those who do have a cycle, monthly mid-cycle is around day 15 for your average 28 to 30 day cycle. So day 1 is your first day of bleeding. Day 28 or 30 is the day before that cycle starts. Day 15 is when your breasts are going to be the least hormonally influenced, and when you're going to get the best assessment of what your breast tissue feels like and the least of those cyclic lumps. So when doing an exam, and I have an entire video reel of this on my Instagram, I recommend women go from their sternum to their axilla, their underarm, their just below their clavicle to below their breast tissue, to start away and roll towards the nipple, or start at the nipple and roll away. The point being, you want to see if something moves with you, because mobility can most often be considered benign. Something that's fixed might be a little bit more concerning. And then our normal tissue might just like roll with us anyway and not actually end up being a mass, as opposed to just sticking our fingers down and being like, oh wow, that feels like a lump. So for your average woman in her 20s and 30s, I'm talking about a monthly mid-cycle exam. For those who are on IUDs, pick a day of the month and do it every month. So if it is the first, that's great. If it's the 15th, if it's the 30th, whatever it is.
Perfect. So all that is extremely helpful, and I think gives some people hopefully some insight on the different screening stuff that exists and what investigation means, why it's prudent, but also not something to be terribly afraid of. I know that's easier said than done, of course. Now, we were talking about before we got on the podcast about this cryotherapy. So I sometimes get DMs. So
Yeah.
DM number 3, DM number 4. What
Yeah.
is this strategy that people are using to go ahead and put in basically a treatment, like deliver a treatment to a lesion, and when should this be considered?
So, breast imaging and cancer therapy is, of course, a team approach, right? It's there's not just one person. The oncologist isn't the only person. I'm not the only person as the breast imaging radiologist. It's not just the surgeon. So, most often, women who are diagnosed with breast cancer, it's been found by one of us, either from a screening mammogram that moved to a diagnostic and a biopsy, or something detected by the patient or their physician on physical exam that then went on to be detected by imaging. Once we have established a diagnosis through a minimally invasive image-guided biopsy under mammogram, ultrasound, or MRI, we're able to most oftentimes do an MRI for extent of disease workup, or if in our younger or more dense breasted women. When I worked in North Carolina, not everyone would get an MRI because some tissue patterns, it was pretty evident, and or, for example, postmenopausal breast cancers in an 80-year-old woman who has not very dense breast tissue and has very low-grade disease. For example, those don't necessarily get MRI imaging. Then it's presented at some kind of multimodality
Tumor board.
breast conference, exactly, tumor board, where we discuss the options. So if you have, for example, a 90-year-old woman whose cancer was either detected by screening or, we get a lot of these like nursing home, Dr. felt, there was an obvious mass, etc. They might not be good surgical candidates either because of their cardiopulmonary risk. There's some sort of situation that might place them at risk for anesthesia or
Right.
healing.
So to summarize, those people considering cryotherapy, if you're young and want the most non-invasive, it is for
Right.
sure, by all standard data currently, inferior to doing standard of care management, which is doing a lumpectomy
Right.
plus radiation versus doing a mastectomy and maybe foregoing radiation. In general, those are the two ways that all breast cancer should be managed, under the age of
Right.
75 and no, glaring contraindications. Now, this question I
Right.
get a lot, and it would be really helpful if you have some insight, which is when women or men are getting, or any individual is getting a lumpectomy, and then they have a decision to make on whole breast radiation versus using a device or other means to get basically intra, mammary or intra breast radiation delivered, which is way shorter. They don't have to go for 6 weeks to the radiation doctor. There's a whole bunch of stuff that definitely sound more appealing or favorable with life stuff. Now, I had a couple of attendings, this was years ago in fellowship, that said the only thing is, Sanjay, if they had a lumpectomy, it impairs or makes the imaging more difficult for future cancers. Do you, to your best of your knowledge, and if there's no literature, that's great too, because I know it's still developing. But should that be a concern of someone that's considering rather than whole breast? Not talking about recurrence. Now, that's a different conversation. But just in the capacity of, will I have an impaired ability to see a second or breast cancer or recurrence if I do the one that's in the breast versus whole breast?
So we definitely see a lot of intraoperative radiation therapy in the DMV where I practice. It's a pretty popular technique with a lot of our breast cancer centers. I don't think it's impaired my ability to detect breast cancer, but I will say, for example, just the other day I was reading an MRI on a prior breast conservation patient, and you are getting signal dropout around some of those devices. So the one that looks like a long wire, so not the BioZorb, which is one of them, not to be vendor specific, but it does allow me to get a little bit better imaging, whereas some of these other ones do cause signal dropout. But mammographically, I feel like I'm seeing sonographically. I understand why patients would choose that if it has better quality of life, which is huge
For
for our
sure.
patients, right? Not just
And the
talking about like
toxicities of a whole breast radiation and,
right,
the field and if it's over the heart or not. There's a bunch of things to consider.
right, yeah,
So
heart and lungs.
it's definitely
So
not
yeah,
just recurrence. Yeah. And
right.
then speaking on the same subject, mental health, self-image, very important things. If somebody was to opt for bilateral breast implants, And I know there's two situations. Somebody may get, for whatever reason, if they can afford it, just like bilateral mastectomies for the high family risk or have some mutation and then get their prostheses, or they just get, what do they call it, enhancements, so they get like bilateral prostheses, they're, size A. How much, literature-wise, does that reduce the chance of finding a breast cancer? Let's say they didn't get mastectomies, they just had augmentation bilaterally. Is it pretty significant?
So you're saying this isn't a breast reconstruction, or just in the average?
This is an average person wanting to
Right.
get, they have smaller size
So,
breasts and they want to get
sure.
augmentation.
Yeah. So my recommendation, often unsolicited, but my unsolicited recommendation to patients looking for augmentation is that um, retropectoral implants do not obscure tissue in most women. So your prepectoral implants, that's the one that's in front of the muscle, we do know that does significantly impair the ability to perform the mammogram, because in women with implants, we're getting minimum 4 views per breast. We're getting one with the implant in view and one with the implant displaced. And when
So
it's
on
behind the
top of the
muscle,
pecs, you're saying that it does impair, but if you get augmentation below,
if you
nothing.
get it under the pegs.
So the next DM question, if I get breast augmentation, I hear that
Mhm.
there's, what you were saying earlier, is that there's a difference in where it is in relation to the pec muscles on if things will be obscured or not with detecting breast cancers with screening, correct?
So, yeah, exactly. Above the muscle is definitely going to limit ability. And then there are some women, even if it's behind the muscle, for example, if it gets capsular contraction, things like that, those are complications that can happen later. But for the most part, women who have implants that are behind the breast, it can obscure, or it can limit our ability to image the posterior aspects of the tissue, but significantly less than those that are in front of the muscle.
Okay.
The other thing is, like, for women who are getting reductions or mammopexy. So mammopexy is a lift. Reduction is, of course, removal of tissue. That can cause some changes inside the breast. A woman might just see the T-shaped scar that goes inferior to the nipple, and then in the inframammary or under the breast region. But really, they're taking tissue from the entire breast. Imagine if you've seen liposuction; it's a similar concept. I'm not a breast surgeon nor a plastic surgeon, but similar concept. And so we're going to see changes throughout the breast. And so I do recommend to women, if they have had any kind of breast enhancement augmentation or plastic surgery, for at least the first mammogram after that surgery, to consider doing a diagnostic, because it's most common to be called back after that first year. So it's not something that they need to do lifelong. They don't always need to get
Right.
diagnostic,
So just get
but
that
definitely,
baseline of like what changed, where's the scar tissue, how
yeah,
does this look different, so that could be the comparison for interval
right.
changes when you see something new in the next year and stuff.
Yeah, and also really good to make sure that before you're doing that surgery, you've had, your mammogram very close to that, because
Oh,
then it
that's a
can
good tip.
sort of help us. It can help us know, like, okay, they had their mammogram March 2022, they had the surgery March 20, in that same month, and then here we are seeing them a year later, and yeah, it's most
That's
likely
a
that
good
these changes.
tip. So the tip is get the mammogram as close as you can.
Full of knowledge here, dropping
That's
knowledge
it.
bombs
And
all day.
give us your handle one more time, just so not the last
At
time.
Yeah, at Anjali Malik MD on Instagram, Twitter, TikTok, with very minimal following as compared to the Onk Doc here.
Well, we love it. I love watching. So that's a very helpful. And do you know if there is any difference on what you use for augmentation? Because I know that some people use like an auto, they use their own, subcutaneous tissue or adipose tissue in their hips or their belly and then put it into the breast. Is that actually more favorable, or does it not really matter since it's the scarring that you're creating to get in there that's mostly the issue?
So we're seeing that more with breast reconstruction in a post-mastectomy patient for breast cancer,
Right. Which, by the way,
or
is covered with a lot of insurance companies. So please, like, a lot of people don't offer it if there's
right,
not a plastic surgeon in town. But if it's, you're
right.
young and you want to get, or you're having to get a mastectomy or bilateral for high risk, for genetics, it is definitely something that's oftentimes covered by insurance to be able to actually get your own tissue replaced in those areas. And they hate, my plastic surgeon friend hates when I say a tummy tuck plus breast augmentation because there's not a time to talk, but like,
Yeah,
you know,
that's not the goal, but yes. So there's tram flap, which is the transverse abdominis, or transverse. Sorry, yeah. And then there's deep flap, and then there's lat flap. Lat flap is not as common anymore, but it was when people were taking the back tissue. So there is a chance of recurrence in those at the anastomosis. The anastomosis is where we're connecting the tissue that's been moved to the minimal chest wall tissue and or just the pectoralis musculature that's there. So those do still need to be screened as though they were real breasts, either by minimal physical exam annually, but also many, especially those who have only gotten one side reconstructed, will have still a bilateral mammogram. And I do want to point out that mastectomy is not always the answer. Of course, you know this, and those of us in the cancer community know this. But with Angelina Jolie in the, I think, mid 2000s, being diagnosed with, now I can't remember if she has BRCA1 or 2, she had a prophylactic mastectomy. That made sense for her and her family history, and it was something that
right,
would significantly impact her lifespan.
right.
However, for many women, that is not the answer. And so, if you're being offered lumpectomy, it's not necessarily subpar therapy.
No, yeah, for sure. And
Yeah.
very important
So,
to either see a geneticist if like you want more
right,
information and you are in a community that can tell you very specifically statistics wise,
right,
and they can be done virtually. Like you said, we had Dino previously, and there's just a lot of
yeah,
doing that. So that's important. If you ever feel like you need more information in the community
right,
and
yeah,
you don't have the specialist in genetics or a plastic surgeon specialist or a surgical oncologist specialist, always like
right,
seek the resources before making life changes decisions so you feel good
right,
about it. Right? Like feeling good about something, oftentimes regardless of
right.
outcome, is extremely important for overall, long-term health, mental health, and
Oh,
everything like that.
absolutely. I definitely think a good working relationship is important with your, surgeon, oncologist, radiologist, et cetera. But what I do want people to know is that more is not always better.
Right.
Sometimes more is just more, right? So the recovery, the chance for complications, risk, et cetera. So we always take that into consideration when we're making recommendations, which at the end of the day are just recommendations, right? So, patients are free to do what they would like with their own bodies, which is absolutely what they should be able to do. But we do, based on outcomes and
Outcomes, literature, seeing, thousands of people in the same exact situation with the same properties and
right,
seeing what happens. That's where the recommendations come
right,
from. And I hope people can
right,
appreciate that. On radiation, this, that, and the other, it's like basically more or less exactly the same situation. We see if
right.
it actually helps survival or doesn't. And that's really how cancer management is in general.
Yeah, and I like to tell patients too that the breast cancer treatment is not one size fits all. So just because, with breast cancer being as common as it is, people will say, well, the woman in my office got this, or
Right.
my grandmother got that, and that was hopefully the absolute best treatment for that person. But it's based on disease, age, of course,
So many
all
things.
this. But yeah, so many factors, and we try to make when we do. I mean, we practice precision medicine, so it's all about the individual patient.
Right. I'm so glad you said that. And also too, like an example with what we were saying with the calculators, the reason we ask about the onset of when your cycle started and then where they end early or late is because you have this turnover. And we always talk on this podcast. If you haven't listened to previous episodes, I encourage you to. Cancer is a product of, turnover over time because the turnover,
Right,
meaning like dead cells die, replicate, make new ones, that's where mutations happen. And cancers are often
right,
a series of unfortunate mutations over a series of time, which is why you get your pap smears, which is why there's DCIS. It means like it's getting there, it just needs one or two more favorable or unfavorable for us mutations to then have
right,
invasive features that are turned into an invasive cancer. So on that same notion, if you're having more cycles, breast tissue swells up and then it comes down, and then all these things. That's what that turnover is where the chances go up, and that's why also after having more than two kids, that's obviously 9 months, 9 to 10 months a piece where somebody's not having cycles, and then of course
right,
then you can have more, cycling arrest when you're breastfeeding, though not all women do. So those are all things that play a
right.
part into it. So
Yeah, absolutely.
this has been
Yeah.
so just edifying, and I hope people feel more comfortable. They know where to find you. Do you, so, I get articles a lot on the DMs, notion about like the newest ways to screen. Well, I hear there's something you could inject and it can just light up and tell you exactly where it is. Uh, inside the whole radiology world, what is, if
Yeah.
anything, something that you all are really seeing may be something that, is more precision based, or for the most part is that, hey, if it looks, sketchy, that's really the most important thing, and then we have a workflow to figure out if it's, really sketchy or if it's something that's avoidable.
Sort of answering your question, but not. I will say that I get a lot of DMs about thermography, and that is not a thing. It does not detect breast cancer. It's not FDA approved, and I don't recommend it at
Okay,
all.
great. So
So,
thermography.
so no thermography, no thermograms. Number two, yeah. So we obviously use all the tools in our belt, and we're always excited about new ones being developed. It does matter what I had mentioned before about access. It's still got to be quick, easily accessible, easily reproduced to be able to make sure that everyone is having access and that we are, in fact, detecting breast cancer across the population. So one thing that is kind of popular right now, there are some new products out there. Artificial intelligence is, always the buzzword when you talk about radiology and cancer detection, and there has long existed computer-aided detection in the AI world to enhance my ability to detect breast cancer. But what is now coming onto the market and still somewhat in its pilot stages is the ability to predict breast cancer development.
Oh,
So there are some products on the market that are looking at tissue patterns and detecting whether or determining whether a breast cancer will develop in a 5 to 10 year timeline. So that is something that I think is exciting. Do I think it's real deal ready for prime time? That remains to be seen,
yeah.
but
That's
certainly more
interesting.
information.
Yeah, and it's a concept that, is in a lot of cancers, because it's not just the turnovers, but a lot of times it's
Right.
the environment, and that's why pancreatic cancer is it's so difficult to treat, is because it uses this microenvironment to really hijack some of your own cells and things like that, as well
Right.
as the settings, right, of like inflammation. That's why like H. pylori can cause like a mole lymphoma. And if you treat H. pylori, it can actually just go away because the environment plays a role in the production of cancers as well. And there's a lot
Right.
of stuff. And if you haven't listened to the previous podcast, we get into all of that in a couple of them on talking about
Right.
how that plays a major part. So I'm really glad you said that.
Yeah.
Well, this was an absolute pleasure. Again, they can find you on social media as Anjali Malik, MD, correct?
MD.
That's
Yep,
right.
Anjali Malik MD. And that's also my website.
That's our website.com. I checked that out beforehand. And then you're in the DC area, so if somebody does want to see you or a consultant or has some disposition in being able to do you do diagnostic radiation, or excuse me, do diagnostic radiologists outside of like being bedside to do the biopsy? Do they actually do consults like in a clinic, or is it mostly just
I
behind the
see
scenes?
patients. I see patients all day,
There you
every
go.
day, most days. So unless I'm reading a screening mammogram or breast MRI, I'm usually patient facing, and so we are seeing them for their diagnostics. In my practice, we do our own breast ultrasounds. We do image guided biopsies. Yeah, and then we also do second opinion, outside consultation, things like that. So certainly an option. Also, as a side note on your cell turnover, just one little tidbit that I like to help my patients understand is this might be too old for you because you are a youngin', but the I Love Lucy, there's an episode where Lucy and Ethel are working at a chocolate factory. And they're making boxes of chocolates, and there's an assembly line, and they're doing a great job. They're making those boxes of chocolates, and it starts going a little fast, and they have an accident, so they put some in their pocket, but just like keeps getting out of control. They're like putting it, they were eating it, they're putting it in their pockets. The boxes of chocolate are not getting made, and that is how I like to explain genetic defects or DNA repair defects to my patients. Is that we're chugging along, we're making those chocolate boxes, and all of a sudden it just gets a little off kilter, and the boxes are not being made.
That's great. I think I've actually heard
That,
that from someone, maybe in a slightly different capacity, but on this podcast, actually. I could be wrong, but that's a very interesting analogy, and I
I
appreciate
shared
it.
it with Dina, so if Dina shared that with you, I'm going to be
I think
mad.
it was Dina. I really do think it was Dina. I could be
That
wrong.
was me. Dina and I did a podcast, and we had, or like, we might have done an IG live, and we had this exact same conversation. So it's
Okay.
okay if everyone is spreading the gospel. I'm okay with it
Yeah,
in
there's a lot
whatever.
of that on TikTok and stuff. I mean, it's literally your exact post with a different person, But I've seen that a
Yeah,
lot of myself. But all
yeah,
that matters is getting education out there. Well, thank you so much.
exactly.
And if you want to learn more, you know where to find Dr. Anjali, and we appreciate you.